Thanks very much, and thanks to the organizers for inviting me to speak, and thank you all for showing up first thing in the morning to hear about this. I'm going to tell you about using dogs as a treatment for, to test treatments for non-Hodgkin lymphoma, and hopefully I can advance the slides. Yes. Okay, so just to set up the problem, most of you know this probably intuitively, but to give some numbers, there was just an article I just saw this morning in JCO about breaking the R-CHOP ceiling for lymphoma. We've been treating lymphoma the same way for many, many years, and it's hard to develop new therapies, and it's inefficient. So as you all know, we usually develop therapies by taking hundreds, thousands, or tens of thousands of compounds and narrowing them down to the best candidates, testing those in the lab with cell lines and mice, and then moving only the best candidates onto clinical trials because the clinical trials are time-consuming and expensive. But even despite that, only taking our best candidates forward, here on this diagram, you can see that there's about 1 in 5 drugs that make it through clinical trials to be FDA approved. In oncology, that's 1 in 12, so we do even worse. And that leads to, because there are now very many failed drugs in clinical trials, a very expensive price tag for each new drug that does get FDA approved. Some estimates say $2.6 billion for each new drug. And it takes 10 to 15 years to develop them. So how can we do better? What my research and other people's research depends on is leaning on our veterinary medicine colleagues. So this is a quote from Rudolph Virchow showing you that it's not a new idea that veterinary medicine can be used as a correlate to human medicine. You can read his quote there. He's the father of human pathology, but he was also a veterinarian, and he noted that there was great conservation between the pathologic mechanisms in different species. This is not a novel concept to veterinarians because they have to learn many different species, but to human doctors, we sort of lost this idea, and it's sort of gaining a renaissance now. So how can we use pet dogs? And I have to preface by saying I don't give any dogs lymphoma. These are pets that come into the veterinary clinic and are being treated for their naturally occurring diseases, including lymphoma. So how do we use the dog model to learn about lymphoma and get new drugs for lymphoma? The first main way is to study the biology, to see what's conserved across species, understanding that the things that are conserved across species are going to be the things probably that are the most biologically relevant. And the second way is to actually do clinical trials in the dogs, using them to expand our knowledge about how drugs work in patients. So just to give you a little comparison between dogs and people to show you that clinically they're very similar. We don't have great epidemiologic data in dogs, but the estimates of the incidence rate are between 20 and 100 per 100,000 dogs per year, and that's similar to humans, which is 20 per 100,000 per year in the United States. So given that there are fewer dogs, but a potentially higher incidence rate, there's probably as many cases of lymphoma in this country as in dogs as there are in people. So lots of potential clinical trial subjects. The pie chart is a little too small to read, but the important thing are the colors. The blue are B-cell lymphomas, the red are T-cell lymphomas, and the green are other. And you can see in dogs and people, they have the majority B-cell lymphomas. In dogs, B-cell lymphomas do better than T-cell lymphomas, just like in people. And the most common subtype in dogs is diffuse large B-cell lymphoma, just as it is in people. And unlike in people, dogs are not cured with CHOP chemotherapy. They get CHOP chemotherapy similar to people. There's not a rituximab yet for dogs. We're working on that. But they can't give such high doses as we give to people because dogs don't tolerate neutropenia well, as you might imagine. And so they get lower doses of CHOP, and they all go into remission, but they almost always relapse. So they're a great model of relapse disease. And they're also a great place to develop new targeted therapies which are less toxic. Here's the histology of diffuse large B-cell lymphoma in dogs and people, and if I hadn't labeled the slides, you wouldn't be able to tell them apart. They look identical morphologically. We then set out to look molecularly to see if they were also similar on the molecular level, looking at some important prognosticators that you all are familiar with. So ABC versus GCB based on gene expression profiling, and double hit or double expressor lymphomas. So this is our work with gene expression profiling of canine B-cell lymphomas. And what we did initially was we used the human list of genes that separate ABC from GCB, and that somewhat separated the dog lymphomas, but the difference was not dramatic, and there was not a survival difference between the two groups. But we used those two groups that we got with the human genes to develop a dog classifier, that had a very highly significant list of over 1,000 genes that separated the two groups. And there was now a survival difference, and the ABC-like subtype did worse. And you can't see it, but the genes that I've highlighted there on the side, if you look at what those genes are that separate the two groups, even though the exact genes aren't the same, differentially expressed between the groups, the same pathways are dysregulated between the two groups as in humans. So the NF-kappa B pathway, the B-cell receptor pathway, those are the genes that separate the two groups in dogs, just like in people. As far as MYC and Bcl2 double expressors, this work was done by a group at Colorado State. They looked at MYC and Bcl2 expression in canine lymphoma, and they actually found, as we did as well, that there was almost universal expression of Bcl2 and MYC in canine lymphomas. So essentially all dogs are double expressors. Maybe this explains why they have such a poor response to CHOP chemotherapy as well. They tried in this study to then further divide those dogs at the median to see if high and low double expressors did differently, but they did not. And then moving on to driver mutations, are they similar? So it's sort of a recurring theme that you might be hearing now. We've looked at, as you know, human diffuse large B-cell lymphoma has common mutations in genes like KMT2D, which is mutated in up to 25%, and some of the other genes, MYD88, EZH2 that you're familiar with, are mutated frequently, but nothing more than 25% of the time. In dogs, it's a similar story. The genes are mutated up to about 25% of the time, and it's a different set of genes, but they're in similar pathways. So for instance, that TRAF3 gene that's at the top of the list is a negative regulator of the NF-kappa B pathway. So we're still in the process of matching up the functional correlates between dogs and humans, but it's starting to look like different genes are mutated, but they sort of affect the same functions. So the molecular characterization is ongoing, but in the meantime, we're moving on to starting some canine clinical trials to try to test new agents that affect these pathways in dogs and people to hopefully move forward faster to get to new therapies for people. And I'm going to explain to you how the dogs can help us do that. We have a cooperative trials network for dogs, just like we do for people. It's not called the Alliance, it's called the COTC. It involves almost all the veterinary schools in the country, and so we can do rather large clinical trials fairly quickly in this network. And the PI here at Cornell is Angela McCleary-Wheeler up at the vet school. She's a veterinary oncologist. So just to highlight some of the things I'm going to show you in the next slide, the ways that we can use dogs in clinical trials to help us advance things in ways that we can't do in people or sometimes in mice. So some advantages of clinical trials in dogs is that the tumors are spontaneous. This is unlike laboratory mice. So these are not genetically engineered. These are not transplanted tumors. These tumors are just naturally occurring tumors, the same as they are in humans, and therefore you can assess things like the microenvironment, cell-free DNA, which you'll hear soon more about. We can also easily get repeat biopsies. So it's very difficult, as you know, to get a human to agree to even 2 biopsies, like a before and after biopsy. But dogs, if you have a scoop of peanut butter and you bribe them, you can usually pretty easily get them to have as many biopsies as you want. And they tolerate it very well, and they usually have peripheral lymph nodes involved, and so it's very easy to follow them with sequential biopsies. For those of you who do clinical trials, we have no need for all of this jargon of INDs, IRBs, GMP. You don't even need to know what those are, but there's just, suffice it to say, there's a lot of bureaucracy and care that needs to go into a human clinical trial for obvious reasons. And with dogs, it's a little easier. We don't have to have GMP-produced drugs, for instance. We don't have any need for an IRB. We do need IACUC approval, of course, but that's usually faster to get. The other nice thing about dogs is that we can combine novel agents right up front. There's no need to test single agents. If we decide we want to use 3 drugs together, we can use 3 drugs together as long as it's safe. And we have the ability to prove that it's safe using research dogs. The other thing is, probably the important thing in the era of immuno-oncology is that dogs have an intact immune system, and it's been educated like ours. So if you look at mice who are grown in sterile cages, they rarely see infections, and so they don't have an immune system that's been trained the way ours has, having infections and colds and antigen exposure our whole life long. Dogs roll in the dirt, lick their butt, they have all kinds of exposure to antigens, and they have an immune system that's very well educated like ours. So to highlight some of those advantages that I just talked about in actual real life what we're doing, the first thing that I mentioned, or one of the things that I mentioned, was novel combinations. So I call this the dog moonshot. We can combine drugs in dogs even before single agents have been tested if there's a compelling rationale to do so. And we just received a grant, actually, from the NIH to do these sorts of trials to try to develop a chemo-free regimen for diffuse large B-cell lymphoma. You can imagine how long that would take to do in humans if you had to drop out 1 drug at a time and try to figure out how to replace R-CHOP, because R-CHOP is very successful in humans. Whereas in dogs, R-CHOP is not so successful. CHOP is not so successful. It doesn't cure any of the dogs, so we're not really losing anything by trying things up front. So we can try combinations and we can use them up front. The first example of the combination that we're using is B-cell receptor inhibitor, ibrutinib, and a BET inhibitor together. And I chose this example because this combination has not yet been put into humans, but there's a compelling rationale for it. It's synergistic in vivo in mouse models and in vitro. And so we're working now to make sure it's not too toxic in dogs, and then we will go ahead and just put it into a clinical trial and see how it does, and have a very quick answer with correlative studies. Those correlative studies, like I mentioned, are very easy. This is a dog, it's a black dog, so it's a little hard to see, but it's a lymph node in a dog getting an FNA. And you can do those for $30, and you can do them each time the dog comes into clinic if you want. So it's very easy to follow along and see what the effects of the drug are and do any correlative studies you want. The other thing I should mention is the dog lifespan is very abbreviated compared to humans, and the disease course is as well. They mostly relapse within a year. So we can do trials very quickly and have answers very quickly. There are also breeds that are very high risk. 1 in 8, I think it is, golden retrievers dies of lymphoma. And so we can do clinical studies of screening and chemoprevention much more easily in the dog within the span of, say, 5 years, which would take decades to do in a human. The last thing I mentioned on the slide, the introductory slide, was immunotherapies. And this is a particularly good place for canine trials. I put this slide on to remind you that immunotherapies are not just PD-1 and PD-L1 inhibitors, but they involve a whole spectrum of things, all the way from monoclonal antibodies all the way up to allogeneic stem cell transplant, which is also an immunotherapy. And dogs, in fact, were involved in early studies of allogeneic stem cell transplants. So we have the capacity to do autologous and allogeneic stem cell transplants in dogs as well. But looking at PD-1 and PD-L1, because that's the one everybody's interested in, It's been shown that PD-L1 is present in canine cancers, upregulated. It's not been shown in lymphoma yet. We're working on that. It's also been shown that PD-1 is upregulated on the tumor-infiltrating lymphocytes. This is in melanoma. It's showing that the melanoma Tcells are upregulated for PD-1 compared to the peripheral blood cells of a normal dog. And then, this is just anecdotal at this point because it's still early days, but we have PD-1 inhibitors just in dogs, just like in humans. And this is a dog with mucocutaneous melanoma. And you can see there on the CT scan and in the photographs and on the graph below that treatment with the PD-1 inhibitor has a similar kind of striking shrinkage of the tumor over time as we see sometimes in humans. So that lets the dog then be the model for figuring out how to make those PD-1 inhibitors work in more patients and with as few toxicities as possible. I put this last slide on here to show another type of trial, immunotherapy trial that we're currently working on with Roswell Park. It's not CAR T-cells, but it is a similar concept, which is finding T-cells in a dog with lymphoma that recognize a neoantigen and then cloning out the T-cell receptor of that of those T-cells and putting them back into the dog and getting a tumor response that way. And that's in collaboration with Richard Koya up there. So just to summarize kind of all the ways that we can think about using dogs to help us find new therapies for lymphoma. We, as I mentioned, are comparing mechanisms of biology across species to find the things that are shared in common and also the things that are different to learn more about the biology of the disease. We can also do trials that can't easily be done in the laboratory, like with immunotherapies. And because we don't have good lab animal models. And we can also do trials that can't easily be done in humans. So that's also immunotherapies. And we can do extensive correlative biomarkers to make those immunotherapies work better. We can do novel combinations, and we don't have to wait. We can put it right in the frontline setting. And I think together that these types of trials that we're now starting to do will establish the value of the canine models to human therapeutic development. And then last, I'd like to thank all the people that have been involved in all this work along the way, both here at Cornell, up in Ithaca, and also at UNC and NC State, which is where I was before I came to Cornell. And then the funding sources, I'm happy to take any questions.